So our next speaker is Dr. Adriane Martin Hilber. Dr. Hilber is a senior specialist in the Sexual and Reproductive Health and the deputy head of the Sexual and Reproductive Health Unit of the Swiss Center of International Health at the Swiss Tropical and Public Health Institute, based in Basel, Switzerland. She has over 25 years of experience in policy advocacy, implementation, research, and project management of large implementation and research projects in developing countries.
Thank you. Dear colleagues and friends and advocates, it's a real pleasure to be here, and I want to thank the organizing committee and Leah particularly for inviting me to come and participate in this great event. I have seen the conference change and evolve over the years, and I can say that this year's conference reflects the coming of age of your efforts. So thank you for having me, and I look forward to seeing you at the next event. But before I get started, I wanted to explain my choice of picture as the backdrop. A spider on her web, on a fence, ironically shaped as a heart. I thought this image well reflected what I wanted to say here today, that as practitioners, we have worked to engage young people, to welcome them warmly, the heart, yet the offer is somehow spiked, the fence. As practitioners, we may feel we offer a safety net, the web, offering protection to adolescents who may see our offer perhaps as less than beneficent guardian, the spider. So let's discuss where we are, what we have offered, what has been the effect, and where do we go from here. So in this presentation, we're going to be looking at how healthy and informed are young people in the Asia-Pacific region. I won't focus too heavily on this because Anderson has already reviewed a lot of the data, so we can go quickly there. And then we'll look at what are we doing about it. What are the interventions, approaches, their effectiveness, and their reach? And then what's the problem? Have we translated that strategic advice, data, and participation into more effective programming? And where do we go from here? The walls, the fences, the potholes, and how can we overcome them? First, let's look at the epidemiological situation as a reflection of socioeconomic, gender, and other forms of inequity in the Asia-Pacific region. And as I said, I'm going to go quickly now because you just saw it. Here's the adolescent birth rate, where things have largely remained the same. Some countries have done markedly better, like Vietnam, others less so. While the reasons for the trends may differ, the net effect is similar. The same or more adolescent pregnancies that are risky and ultimately limit young women's opportunities in their future. And as was mentioned previously, the issue of the disparities within countries, unfortunately, is also growing. If we look at maternal mortality, the mortality rates of girls remain unacceptably high, even if progress has been made in recent years. STIs are on the rise, with 16 to 19% of sexually active 15 to 19-year-old girls and young women in Indonesia, Mongolia, and Nauru reporting symptoms or having had an STI in the last 12 months. And recent data from UNAIDS indicates that the figures are not improving. Many presenters have spoken about violence against women. While all are unacceptable, the over 30% figure from East Timor are particularly alarming and may signal deep problems in society where patriarchal traditions and a history of armed conflict, as seen in Timor-Leste, contribute to a widespread violence against women. And as also discussed previously this week, the HIV prevalence rate among young people, particularly among marginalized populations, is not getting any better. I'm going to skip over these a little bit. We talked about body mass index and some of the problems and the adolescents not living with either biological parent. And while the reasons may be related to migration and other issues, they're also associated with some of the highest adolescent pregnancy rates in the region. And then finally, of course, there are the underlying issues that put young women and girls in a position of vulnerability. Early marriage and the accompanying early childbearing rates in the region, particularly in some countries, remain staggeringly high. So what does this mean for health inequities in healthcare services and the provision of services? How do these statistics relate to the services they need, want, and are offered? Access to family planning for adolescents has a mixed record with recognized improvements in recent years. Despite progress on unmet need in some countries, particularly among 20 to 24-year-olds, there still remains a significant gap. Barriers to accessing healthcare services when you're sick. When we review why 15 to 19-year-olds don't go to the health services when they are sick, the issues are quite clear, but only partially what we would expect. Naturally, cost, as was mentioned previously, and permission from parents or guardians remains issues that we well know. But there is also an overriding issue of not wanting to go alone. Surely that is something we could have overcome, isn't it? I mean, we have been working on these programs for years, and if they're afraid to go, it seems something that we could have done something more about. And when we look at skilled birth attendance, maternal and newborn care, culture and belief in the system play a part. We note, for example, that where there is early marriage and high adolescent pregnancy, there is also low utilization of skilled attendance at birth, compounding the life-threatening maternal complications these young people face. So that's for the data part. Now we know what the problem is. What are we doing about it? Well, we have lots of ideas. Globally, the evidence has been reviewed, synthesized, summarized, cataloged, dumbed down, made into checklists, algorithms, guidance, best practices, infographics, notes for scaling up, to name a few. Each of us that work on programming for adolescent health has seen some, if not all, of these documents and tried diligently to take their advice. Indeed, many of us have participated in these processes to ensure that we know what to do to meet the information and service needs of young people. The recent WHO and UN partners' Global Accelerated Action for Adolescent Health, or the AHA strategy, has provided a strong summary of what is needed to improve programming for young people. Recommended actions include situation analysis, adolescent health profiling, stakeholder mapping, engaging adolescents in the design, implementation, and evaluation of programs, multi-sectoral interventions, age-appropriate interventions, and respect for rights, gender, and the special needs of marginalized populations. I think we know many of these and know that they're extremely important if we're going to have an effective adolescent health program. In terms of life skills education and information, in terms of SRH and HIV information and education, it has been provided to in and out of school adolescents and young people through a variety of means, but all basically aiming to deliver life skills education and information and/or comprehensive sexuality education or some form thereof. Ways in which education and information have been delivered has varied, but most include some kind of peer or teacher-led intervention sessions delivered in schools, whether they be public or private, vocational, universities, police, military academies, children living in boarding schools or other institutions, and out of school. We all know the list: school clubs, extracurricular activities, youth centers, discrete peer education programs, hotlines, media, social media, radio programs, safe spaces. We're all aware of that because, and I personally, because I've tried, I think, most of them. When we think of, but to meet the health needs of young people, we have also tried numerous approaches over the years, including a variety of forms of youth-friendly services and service packages, usually accompanied by extensive training of providers to deliver services that are friendly, confidential, they respect privacy, allow for anonymity, reduce service access barriers such as fees, physical access, the time when they are available, and so on, separate entrances. All of these things we know and we have tried in a variety of different forms and formats. And right now we have an enabling environment. There is a particular moment in time, I think Sophia Gruskin said yesterday, we were talking about the very special point in time where we do have a lot of opportunities and of course the converse constraints politically. There's heightened attention to adolescent in recent years due to global advocacy and recognition of the triple dividend of investing in youth and how that has yielded increased political commitment globally and in countries. And I would say that not the least of that is due to the global strategy for women, children, and now adolescent health, and the SDGs. This in turn has provided the necessary funding and support for multi-sectoral programs and projects that have successfully identified and addressed barriers such as restrictive parent and spousal consent laws in some countries. I know in the Asia-Pacific region there was a full review of legal barriers that were tackled by UNFPA and others. There's also now more awareness of the evidence base of what works, including the importance of youth participation in programs that affect them. This is increasingly being done through the support to youth initiatives, campaigns, and advisory panels. So if we know what to do, we have the guidance, we are out there in the field, we are working with young people, what's the problem? Why is the strategic advice, data, participation not yielding better numbers, better services, and healthier, more informed young people in our region? And here, I guess, is where we start to make excuses, usually involving lack of funding, government lethargy, corruption, bureaucracy, social and cultural norms, the rise of fundamentalism, discrimination, and so on. I would like, however, to pose an alternative explanation for what's going on. The barriers we know, and perhaps some we don't know because young people don't share them with us, continue to create walls, fences, and potholes on the road to making services accessible, available, appropriate, and most importantly, used by the young people they are intended for. The messages we provide through our education and information efforts also often misses the mark because they have often been negotiated so heavily that the messages become narrow, single issue, pregnancy prevention, HIV prevention, abortion, and frankly, rather dry. They're just not sexy. That's it. In the age of tweets and YouTube clips, who has time to listen and concentrate on the messages from a teacher or nurse you don't trust, even if they're really well trained? In our programming, and I would say mine as well, naturally, despite best intentions, we often miss the mark. If the mark is services and programs that are available, appropriate, accessible, and of quality to young people, then too often we fall short. Our projects, if we are honest, are excellent pilots with great potential, if we modify a few things. They are strategies and approaches that tick the boxes, but perhaps had to compromise a bit to meet targets, deadlines, available funding cycles, partners we had to include. And as a result, we end up offering a good service package that isn't as anonymous and confidential as they should be. We have providers and teachers that have been trained and maybe even retrained, but still have not fully managed to overcome their biases to deliver truly non-discriminatory, respectful information or care. Or we managed to secure insurance coverage for key services for youth, perhaps even without legal restrictions, but the organization of the services themselves proved to be insurmountable hurdles for the young people to overcome. A big part of the problem is the context. Services have not been designed for young people. They are not friendly, by definition. Teacher, parents, providers are not the go-to people young people want to speak to with their private, worrisome, and even exciting personal information. The messengers are not necessarily trusted. In addition, I think most young people would say, they don't understand. We adults have to recognize that we probably don't understand. And everywhere, shame, shyness, stigma dominates the list of concerns that limit young people's ability to reach out and benefit from the education, information, and services offered that they may come across. And as a result, we end up serving young people that are not those in greatest need, and perhaps would have found a way to get the service and education without our intervention. Middle and upper class kids, and not the most marginalized, nor those with special needs. Small projects and true exceptions exist and are around and need to be highlighted more. So I go back to the problem. There are barriers. We know mainly what they are. We have been told many times by young people themselves what they are. We also understand what is needed to overcome them. though admittedly more challenging to deliver than a drop-in center or a peer education program. So why don't we have more success? Why can't we speed up the progress? I think it's because we are not really listening. We hear the issues, but perhaps we think we know best. We can't change, or are so entrenched in our strategies and approaches that we do not create enough flexibility within what we are doing to take the suggestion that our, quote, clients, young people themselves, have said are needed for the program or service to be effective. Certainly it's complicated, but one can appreciate that it can appear that they are not being heard. So where do we go from here? How do we break down the walls and fences that we are told are insurmountable hurdles for young people? I propose partnership, not patrimony. We have a chance to stand in partnership with young people to decide together how to best meet their needs in ways they want to be reached. The leaders and advocates are all around us. We just have to give value to their voices and trust they know what matters to them and how to reach them. We do it in other spheres. Why not in development programming? I'll give you the Coca-Cola example. We talk of public-private partnerships, so perhaps we can learn something from the private sector. Everywhere in the world, almost everywhere, you can get a Coca-Cola. They know their clients, they know where they live, they know how to access them, they know what kind of soft drinks they like, they even know the color of the can. It's all been well studied. Indeed, Coca-Cola reaches the last mile. So why are we not so successful? Why are they so successful, even if they may have an awful product? Because they listen to their clients. They take their advice, adapt their systems accordingly. We have to start listening and adapt ourselves, our programs, our investments to the needs if we are really to leave no one behind. Fundamentally, it's about respect for young people, for their views and perspectives, and confidence in their capacity to guide us in efforts to support them. It's only through true respect and partnership that young people will become actors and agents, not merely beneficiaries in their own health, and we together can improve their health and well-being. Thank you.
Thank you so much.